Hi everyone, I am Dr. Himadri. So today our topic of discussion is short stature. Actually, this is very important topic in pediatrics. So in this video, actually we have two parts, part one and part two. In part one, we will be discussing definition of short stature, anthropometry, followed by the etiology and the causes of short stature. In part 2 of the video, we will be discussing the actual clinical approach to a case of short stature. Initially history taking, followed by examination, then investigation, then the treatment part of it. So in approach to short stature, initially the birth history is very important. If the birth history we find the child to have small for gestational age, that is IUGR. Look, not all IUGR cases present with primordial short stature. Only 20 to 30% have short stature, but the 70% child doesn't have short stature. They usually has normal growth after 2 years of age. So only 20 to 30% cases we have short stature, and we call it primordial short stature. Okay. So in birth history, another thing is very important for our congenital hypopituitarism to know. That is, in case of congenital hypopituitarism, you must be knowing that there is hypoglycemia. So this hypoglycemia could be either symptomatic or it could be asymptomatic. If it is asymptomatic, you have only hypoglycemia, but symptomatic, there may be seizure. So hypoglycemia plus minus seizure, breech presentation, and also history of neonatal jaundice. History of prolonged pathological neonatal jaundice should be there in case of congenital hypopituitarism. Please note it. So from birth history, these two things are very important. Okay. Just another thing, what is small for gestational age we are discussing. Small for gestational age means in the curve, that is weight versus weeks of gestation curve. If it is less than 10 centile, we call it small for gestational age. That is weight for weeks of gestation, weight versus weeks of gestation curve. If it is less than 10 centile, we call it small for gestational age. Okay. Or IUGR babies. Suppose we have a child 34 weeks of gestation and having weight of only 1 kg. The child will be small for gestational age or IUGR baby, as it is less than 10th centile. Okay. Another thing in the history is that in case of malnutrition, you know that in case of malnutrition, you will get like you have to search for the different causes, like it may be underlying congenital heart disease, or it could be persistent chronic diarrhea, and steatorrhea will be present in case of celiac disease. And you have to know the other causes like the chronic illnesses, like if there is any history of cough and cold and repeated exacerbations in case of asthma, or it could be congenital heart disease. That is, the history should be classical, that is poor feeding and suck cycle, as well as during feeding there is excessive sweating in the forehead of the child, or it could be the cyanosis of the child. These are some from history you will get it. Suppose let's say in celiac disease, there will be chronic diarrhea. Now the endocrine cause, very important cause, is congenital hypothyroidism. So in case of congenital hypothyroidism, the history, from birth history, there would be the prolonged jaundice and feeding difficulties, lethargy, and after that you will get there is umbilical hernia, and abdomen is enlarged abdomen, macroglossia, there will be constipation, abnormal cry, like that. So another, once again, there is umbilical hernia, protuberant abdomen, there is and the very important thing, posterior frontal is wide open. So look at the child, there is hypotonic posture of this child with wide abdomen is enlarged. And look in this photograph, there is umbilical hernia, macroclosia, and edematous space, that is mixed edematous space. Another photograph showing all those things. So the another very important cause is congenital hypopituitarism. So to understand congenital hypopituitarism, the normal development of the pituitary gland you should be knowing. So actually what happens, from the posterior portion of the nasopharynx, there is Rathke's cell. These Rathke's cells are migrated in the midline from the posterior pharyngeal wall to, and eventually it goes upward. And in the migration process, you need some molecular motors that will transmit you. Actually, the gene is prop1 gene. From that gene there is byproducts of protein that basically transmits those cells, and it goes and joins with the stalk and also the posterior pituitary. That is how the development actually happens. But the issue is there is mutation in the prop1 gene, therefore there is no protein as a molecular motor for transmitting those, for rather location of the translocation of these Rathke's cells. So actually what happens in somatotrophic cells, that is your growth hormone releasing cells, the somatotrophic cells there is absent. The somatotrophic cells which basically produce your growth hormone are absent there, as well as the another issue is your gonadotropic cells, that is LH and FSH are not produced. So gonadotropic cells, LH, FSH are not produced in this congenital hypopituitarism. Actually, the anterior pituitary is mainly involved with the somatotropes as well as the gonadotropes. So as there is no growth hormone, automatically the IGF-1 is not produced. As there is less IGF-1, there is short stature. As well as you can see in these patients there is midline craniofacial abnormalities, because we were discussing that there is the Rathke's cells eventually from posterior pharyngeal goes upward. If it cannot go, there will be some midline craniofacial abnormalities. And in these patients also we have hypoglycemia, there is central obesity, and also there is low LH and low FSH, there is micropenis in this children. So the midline craniofacial abnormalities are like crowding of teeth and single central incisor, bifid uvula. All these things you can see. There is depressed nasal bridge and frontal bossings. In this child you can see there is obesity, central obesity is present. So look at the MRI of this patient. In the MRI, at first the normal one. In the green arrow you can see there is anterior pituitary. But please look at the yellow arrow. This is it's like a posterior pituitary bright spot. So in the Rathke's pouch there is anterior pituitary as well as the posterior pituitary, and in the blue arrow, which is the stalk, blue arrow means the pituitary stalk, and after the pituitary stalk in the we have anterior and posterior pituitary over the Rathke's pouch. So now look at the abnormal MRI finding in case of congenital hypopituitarism. Look at the yellow arrow. In the yellow arrow, what you can see, there is a hypoplastic anterior pituitary, and the red arrow you can see there is posterior pituitary bright spots. So the anterior pituitary is present, but this is hypoplastic, and there is ectopic posterior pituitary. So in the congenital hypopituitarism, you can see there is short stature with micropenis with central obesity of the child. All these things, and this is bifid uvula, midline craniofacial abnormality, which is seen in congenital hypopituitarism. Bifid uvula. This is micropenis. So to diagnose a case of micropenis, you must know how to diagnose it. A stretch penile length is taken, and there are some normal cutoffs. If the length is less than that, we can call it micropenis. In case of neonate, it is less than 2.5 centimeter. In case of child, it is less than 4 centimeter. In case of adult, less than 9 centimeter, we call it micropenis. Okay. Now let's talk about how to take history in case of a few syndromes like Down syndrome, Turner syndrome, Noonan and Prader-Willi syndrome. And these are very important cause of short stature, pathological short stature. Okay. So this is a Down syndrome child. What you have to look for, there is flattened nasal bridge. So in the history, when a patient is coming, you must be looking for all those things. In case of evaluation of short stature, there is flattened nasal bridge, as well as you can see there is epicanthal fold. Epicanthal fold means the extra amount of tissue in the upper eyelid which is covering the inner aspect of the eye. There is wave neck, as well as the one that is wave neck or short neck, and low set ear. And look at the palpebral fissure. Palpebral fissure is upslanting palpebral fissure, you can see in this patient. So once again there is depressed nasal bridge, and also the epicanthal fold palpebral fissure is upward. This upward palpebral fissure is called as mongoloid slant. Look at this. There are three slants. So mongoloid slant and anti-mongoloid slant. Anti-mongoloid slant is something which is seen in Noonan syndrome. We will discuss shortly. So look, here we have another patient. In between the first toe and the second toe, there is a gap. And in this picture, you can see there is clinodactyly. Clinodactyly means short little finger as well as inward bending of the little finger. So now talk about Turner syndrome. So what will found in Turner syndrome is that we have 45x0. This is the karyotyping of Turner syndrome. The most characteristic thing that you will find in the hand is short fourth metacarpal, and also there is short stature. This is a Turner child. Look at, there is short stature with short fourth metacarpal with wide shield shaped chest, and there is short neck or wave neck, shield chest, short stature. Fourth metacarpal is short. And look at the elbow joint of this child. In the elbow joint you can find there is cubitus valgus. Now look at this. This is Noonan syndrome. You can find there is wave neck, and also there is short stature. And this Noonan syndrome actually occurs due to mutation in the PTPN11 gene. Okay. So as with the short stature, you can see that the ear of the child is posteriorly bent, and the slant is anti-mongoloid slant. Okay, after the history is done, now this is the time for anthropometry. So we have already discussed in detail the anthropometry in the first video. Please go there and watch it. After anthropometry is done, we have few data within which we have already collected. The child could be 0 to -2 standard deviation in the growth chart, or it could be -2 to -3 standard deviation, or it could be less than -3 standard deviation. If it is 0 to -2 standard deviation, we have to only wait and watch. In case of -2 to -3 standard deviation, mostly we talked it earlier, that mostly this is physiological short stature. We need to look for the growth velocity. That is, we must ask the child to visit in 3 to 6 months interval, and we have to plot it and measure the growth velocity. If it is more than 4 cm per year, there is no issue, just wait and watch. If less than 4 cm per year, that means the growth curve is going to be either flat or downwards. Now it could be pathological, so we have to investigate. So if the child's height for age is less than -3 standard deviation, just we have to go for we have to classify it as pathological and investigate. And if the growth velocity is less than 4 cm per year, once again we have to investigate. So in case of investigation, we have 3 tiers of investigation: tier 1, tier 2 and tier 3 investigations. Tier 1 investigations, we must try to rule out or rule in few important common cause. And to do this, we need to have CBC with ESR, LFT, RFT. In RFT, you have serum urea, serum creatinine, and you have to go for that is bone profile. In bone profile, we have serum calcium, serum phosphate, alkaline phosphate ALP. We have serum total vitamin D3, and as well as 1 hydroxycholecalciferol and 125 dihydroxycholecalciferol. So this bone profile you must be ordering. Please remember, along with this, you have bilateral wrist joint X-ray. You have to look for bilateral wrist joint X-ray for bone age estimation. We have another video for bone age estimation. Please, you can watch it later on. So another thing, that is urine REME CS you must be ordering, because to know that if there is any UTI or chronic kidney disease CKD. And also you have to be knowing the stool RE, and from stool RE, if there is worm infestation, there will be the presentation will be like chronic, and there will be protein energy malnutrition. In stool RE, you can have steatorrhea. From there, you can have an idea about celiac disease or like that. And also please order serum albumin and also transaminase, serum albumin and transaminase. And from serum albumin and transaminase, the chronic liver conditions, you can have an idea about the chronic liver conditions from this. And another thing is very important, that is fasting blood glucose. Please don't forget it, because in fasting blood glucose, in case of congenital hypopituitarism, we can have an idea from this, if there is fasting hypoglycemia. So after tier 1 investigation, we have tier 2 investigations. The very important thing about tier 2 investigation is that suppose the child has hypothyroidism. So to investigate this, we have thyroid profile, TSH, T3 and T4. And in case of Turner syndrome, we must be ordering, there is karyotyping. You must be ordering karyotyping in case of Turner syndrome. So in case of tier 3 investigations, you have celiac disease. For the celiac disease, anti-TTG must be ordering. And also growth hormone provocation test. Earlier we were doing growth hormone provocation test by insulin, but please don't do this, because this is not done right now. You can have glucagon, because insulin has done blunder earlier, because insulin can cause hypoglycemia and the patient can die. So growth hormone provocation test, as well as IGF-1, that is insulin like growth factor 1, and IGF-BP3, the insulin like growth factor binding protein 3, these are done, as well as MRI brain. And we have talked earlier that how the MRI brain should be interpreted and why you should look for MRI brain, like for congenital hypopituitarism. Okay, so the tier 1 investigation done, tier 2 investigation, tier 3 done. Suppose after doing all those investigation of tier 1, 2 and 3, still you are not able to find out any cause, you can stamp the case as idiopathic short stature. Idiopathic short stature means you don't know the actual cause. So after the approach, we can have the treatment of this patient. Inside treatment, we have some general treatment options and some specific treatment options. In general treatment options, mostly the cause is nutritional. We talked about the most common cause is chronic malnutrition, protein energy malnutrition. So the diet chart should be given to the patient for improvement of the nutritional status, as well as please give zinc. The dose is 10 mg per day, which is given for 3 to 6 months. Inside specific treatment, if you have diagnosed the specific cause, please give the specific treatment for the patient. Like for growth hormone deficiency, you have to give growth hormone. For hypothyroidism, you have to give thyroid supplementations, like that. In different disease condition, different treatments. Okay, now let's talk about the growth hormone as a treatment option. So what are the indications when we give growth hormone? We give growth hormone in congenital hypopituitarism, growth hormone deficiency. If there is idiopathic short stature with low growth velocity, that is less than 4 cm per year, this becomes an indication. As well as a few syndromes. Please, the important syndrome where we actually give it is Turner syndrome, Noonan syndrome, Prader-Willi syndrome. all those syndrome we can actually give growth hormone. As well as the growth hormone can be given in primordial short stature, that is short stature associated with SGA, short for gestational age, or that is small for gestational age, or IUGR child, primordial dwarfism. These four indications you must be knowing, that is growth hormone deficiency, idiopathic short stature with low growth velocity, and some syndromes, Turner, Noonan, Prader-Willi, and primordial short stature, that is primordial dwarfism, IUGR associated. So another thing, the growth hormone which we give is actually given these days a recombinant human growth hormone, RHGH, recombinant human growth hormone. The dose is 25 to 50 microgram per kg per day, which is given single dose, once daily dose, and it is given on subcutaneous route at night. Subcutaneous route at night, once daily dosing. Okay. So once you know when to give growth hormone, you have to know when to stop it as well. Because in case of boys, suppose the bone age, look, you can give growth hormone till there is no fusion of growth plate. After the fusion of growth plate, you just can't give it. Like in boys more than 16 years and girls more than 14 years of bone age, there will be growth plate fusion, so there will be no effect of growth hormone. So after that you have to stop it. Suppose if there is no response to growth hormone therapy, that is growth velocity is less than 2.5 centimeter per year, that means there is no response to it. In this case we can also give it. Okay, thank you.